To have everyone here and our great speakers, and just appreciate your time for this continuing education course. For those of you who don't know who I am, I'm Joanne Silverman, Executive Director of Fetch. And Fetch, just so everyone knows, we stand for Furthering Education and Treatment for Companion Animals. Our mission is about educating the public, veterinarians, specifically about pet cancers. We also have a fund called Companions in Crisis, which you all can refer people to us for funding for cancer treatments for their pets. We also have a rescue pen pals program where our dogs, adoptable dogs, are trained in 3 Virginia prisons and then available for adoption. So without any other things, I'd like to introduce our first speaker. Dr. Kristen Parker is with Dogwood's Emergency and Specialty Center, Internal Medicine, and she will be speaking on chronic hepatitis disease in geriatric dogs. So thank you.
Good morning. My name is Kristen Parker, and as excuse me just a second. As we were discussing earlier, technology and I sometimes don't get along, but we'll just leave that where it is for right now. So I wanted to talk to you today about, as we were discussing, I wanted to talk to you a little bit more about chronic hepatopathy and chronic liver diseases in dogs. One of the things that we always seem to think about with them is that when it comes down to, just a second, I also keep notes on all of my talks. When we're talking about chronic hepatic disease of dogs, and particularly of geriatric dogs, part of what we think about is that should be a fairly straightforward, fairly easy topic to discuss. What we're actually going to find is that in most cases, these diseases are a little bit more involved than what we think about. When we start talking about it, we start to say, okay, let's look a little bit at the background for these guys. Why is this important? What are we looking for? Also with geriatric diseases, what are some of the things that we expect to see in dogs? What are some of the abnormalities that we also expect to see? What are some of the common clinical pathological findings and diseases? I'm going to focus on 4 fairly broad areas: neoplasia, primary and metastatic, copper-associated hepatopathy, more because that's becoming more and more common.
Excuse me. They have a problem here, and I have a microphone inside
Oh.
here. And can you lift your laptop up?
Oh, yes. Sorry, they're going to make me louder. So, all right. Okay. Excuse me.
That's okay. Testing, testing, 1, 2.
I will also try to speak more slowly.
Testing, testing.
All right.
Hold that for me.
Yes, thank you.
Okay. And I will put this right here so you can see I have your laptop up.
Oh,
I'm sorry,
wonderful.
folks.
All right. Okay.
And in there.
That makes sense. All right.
Stay. Don't.
All right.
Good.
Okay. Can you guys hear me better? Oh, good. Should I start from the beginning again?
Can they hear you?
Okay.
I mean, can the people in the back hear her?
Oh, good. All right, wonderful. Thank you. Sorry about that. No, so as I was saying, the diseases that I'm going to focus on are neoplasia, primary and metastatic, copper-associated hepatopathy, chronic hepatitis, and briefly hepatocutaneous syndrome. And I'm going to go over some of the diagnostics, both the ones that we have currently, but also the ones that are coming on the horizon. I'm not going to talk about treatment at this point, more because when we start looking at that, that's beyond the scope of this discussion. So some of the background. Dogs are actually a very important member of our families. As we all know, we're all veterinarians. We are all used to this. But we also have found that there have been several advances in healthcare and preventive medicine, and it's increased the life expectancy of dogs. So what we're seeing is we're actually seeing an older population of dogs as we move forward in veterinary medicine. Some of the reasons that we have that is because of vaccination, a better diet. Some people say living in an urban or a suburban environment as opposed to being dogs that are used for hunting. Not that there's anything wrong with that, but we just have a slightly different population, and the expectations for those dogs are a little bit different. The other thing is that geriatric medicine and geriatric care is becoming more popular and is becoming more involved. What did I do there? Okay. All right, there we go. Sorry. So a little bit more background on the liver. The liver is the detoxification center of the body, and it literally is in the center of the body when you think about it. And everything that enters the body must go through the liver, and this includes things like our drugs, toxins, food, bacteria, viruses, virtually everything. The other thing to remember is the immense regenerative capacity of the liver itself. When we start talking about the liver, you'll sometimes hear rumors about if you remove part of the liver, then it will grow back to a normal mass. The other thing that we look at is when you're looking at liver disease and liver failure, you don't enter failure until you've lost 70 to 80% of the functional capacity of the liver. And so when we also look at this, we also say liver enzymes increase in a prehepatic, hepatic, and posthepatic reasons. This means an increase in liver enzymes can just as likely be due to a non-primary liver disease as to a primary liver disease. The things that I think of are Cushing's disease and hypothyroidism. So we start to see where there are other things that are going on that can play a role in what we're seeing when we're evaluating an older dog. So when we start looking at lab results and lab tests, we have to think about multiple things. Now, depending, so now when we're talking about geriatric dogs, when I think of a geriatric dog, depending on the breed, I usually think of greater than or equal to 7 years of age. Now, for some of our smaller breed dogs, that's going to be a little bit older. For some of our larger breed dogs, that's a little bit younger. So the 7 years is more of a rough estimate. And like people, geriatric dogs have certain physical characteristics that happen as they age. Age is not necessarily a disease, but things change as we mature, as we grow. I mean, yeah, you're chuckling. I'm like, yeah, I hear you. You know, and so some of these changes can be subtle, and it can include things like muscle loss, a slower gait, maybe cognitive dysfunction in some of our very old dogs, a change in demeanor. These are things that we look at and we say, okay, well, maybe you're just getting a little bit older. But other times we say, is this something that's more significant? Does this actually indicate liver disease? We also see comorbidities, chronic kidney disease, hypothyroidism, Cushing's disease, diabetes, osteoarthritis, brain tumors. And the other thing is that a lot of these dogs are going to be on supplements and medications for other diseases. So this is also playing a role in how we assess any of our patients and also what we expect to see with them. Now, the historical and physical findings that when I look at this, I think, okay, when we talk about aging, what are some of the things that we see in liver disease, but also what are some of the things that our clients and our owners will come and say to us about what they're finding? So maybe they'll say, you know what, they're PUPD. Maybe it's subtle, maybe it's slight. Maybe they're just saying, yeah, they're just drinking a little bit more water. Maybe there's weight loss. Maybe there is muscle mass loss. Maybe they have a decrease in appetite. There's vomiting, diarrhea. I say mental dullness and hepatic encephalopathy, but even lethargy. You know, how do you qualify lethargy at that point? Do they have ascites when you look at them? The owner comes in and says, yeah, my dog's abdomen is big and it's just blown up like a balloon recently. when you do your physical exam, do you feel hepatomegaly? Do you feel a lumpy, bumpy liver? Do you feel something that shouldn't be there? A lot of it is dependent on the type of the disease. The other thing is, you may find that someone comes in and they say, yeah, this has been slowly going on for the last 3 or 4 weeks. In other cases, they say, literally, my dog was fine yesterday, and now this is what I have. And so this opens up a broad range of what we're looking at and what we're trying to assess. And so when we start talking about that, we have to assume that some of our patients are going to be subtle, and some of these changes are going to be subtle. So what do we do? Most of us now do run semi-annual blood work in our geriatric patients because we're looking for these things. We know that you miss more for not looking than for not knowing, and we don't want to miss chronic kidney disease. We don't want to miss liver disease. So we're looking for these things. And honestly, it's a great baseline. Some people will try to tell you, some of your clients will say, well, you just did blood work 2 months ago. Things can still change in that time frame. So oftentimes I'll say, do your minimum database, do your CBC, your biochemical profile, your urinalysis. Oftentimes in our older dogs, I'll also do a urine culture and sensitivity, because what I'm looking for is, I've got a dog that is older. Like I said, age is not a disease, but things slow down. What if their immune system is not quite as functional as it was when they were 5 years old or even 3 years old? So doing that gives us a little bit more information. An interesting aside, which is maybe completely useless, but it's useless trivia that I find fascinating. They say in people, urinary tract infections can also affect cognitive function. And that, and it's one of those things. I haven't seen that written in dogs. I don't think anybody can assess that right now, because how do you say to your dog, how do you feel today? But that's another story. I also tend to look at a total T4. If you find that the total T4 is low and you're going, is this hypothyroidism or is this something else, do your TSH. Look for that also. I've added thoracic radiographs. That is considered part of a minimum database at most universities. Once again, I look at that and I say, okay, if I'm looking for something else, if something on my physical exam just doesn't add up, or I want to make sure I'm not dealing with a primary heart condition, I'm not dealing with something like a neoplastic change or lung tumors, go ahead and do it. Certainly one of the differentials in dogs that have lost an appetite is there a mass, an intrathoracic mass? So I tend to look at those things as well. Now, other things that you may find with your clinical pathologic findings vary depending on the type of, depending on the disease, the stage of the disease, and the degree of liver involvement. Like we said earlier, 78 to 80% liver loss before you see functional hepatic failure. Biochemically, we look at the ALT, AST, ALK, PHOS, and GGT. Those are all on our standard profiles. Oftentimes, I'll look at albumin. Why? Because if I've got enough liver damage and a liver loss, I expect the albumin to be low. If we're at early liver failure, though, or early liver disease, albumin's going to be normal. So it's one of those things that when I see it coming down, I have to say, is there loss or decreased function? Well, if everything else looks normal, what if this is decreased loss? Bile acids, occasionally I will go ahead and look at those, but once again, it's not the first thing that I reach for. I look at my other parameters, cholesterol and BUN. Some of these dogs are also going to be hypoglycemic, but once again, that usually is either advanced liver disease or certain tumors that you can have of the liver itself. Oh, low cholesterol. Typically low cholesterol, because cholesterol is manufactured in the liver. Now, with some forms of cholestasis, you will also have high cholesterol. So I tend to look more for low cholesterol if I'm worried about chronic liver disease. Thank you, yes. So in going back a little bit more to some of our clinical pathologic findings, basically at this point, the ALT is considered the gold standard for hepatocellular injury. We know that because it is contained within the hepatocytes. Now, the degree of increase is roughly proportional to the disease severity. Now, there are some caveats with that. One of them is that it may not if you have decreased functional liver mass. So if you have a sliver, you're not going to be producing much ALT because you don't have enough left to actually cause an increase. So in those cases, you may find a dog that comes in that's very sick, and you're saying, well, wait a minute, I think you have liver disease, but your ALT is normal. It's the fact that you don't have any functional liver mass left. Same thing with ALK PHOS. The other thing is that you can have non-inflammatory causes of liver disease, like non-inflammatory primary and secondary neoplasia. As an aside, and this, I'll get into a little bit this later, but Labradors right now are being studied quite a bit for chronic liver disease because we found copper-associated hepatopathy with them. So right now there's a lot of research out for them. And so in one study, they took 191 clinically healthy dogs. When they compared the ALT, they found that it was only 45% sensitive in acute hepatopathy, but it was 71% sensitive in chronic hepatopathy. When I look at those numbers, it makes me a little bit nervous because now I'm looking at this going, okay, there's still stuff that I'm missing. Now, to keep in mind, this study in Labradors came out of Utrecht. When they looked at these are dogs that are actually related to other dogs that had been confirmed with a diagnosis of copper-associated hepatopathy. So some of the population is going to be a little skewed in that, but these are the numbers that we have. In that study, they also looked at alk-phos and bile acids, both of which were they were even less sensitive at that point. Now, what can we expect to see? In the early stages, we expect to see our biochemical markers markedly increased. And once again, this is where we expect to see them. And early stages may be, quite frankly, a tough thing to call. More because as we're looking particularly at Labradors and some of the information that's coming out about copper-associated hepatopathy, what we're finding is what we consider early may not actually be early at all. But we don't have that. So for right now, the literature is saying this is what we find in early diseases. So initially you have a markedly increased ALT and alk-phos, but recent research is saying maybe that's not the case. As functional liver mass decreases, the markers decrease. Hypoalbuminemia we see in advanced liver disease. Cholesterol and BUN also decrease in advanced liver disease. You may find hyperbilirubinemia. If you have a dog who comes in who's icteric, right there you're saying it's either pre-hepatic, hepatic, or post-hepatic. But if you've got a small liver, you don't have evidence of pre-hepatic disease, so hemolysis, now you're looking more likely at liver disease itself. The other thing is that while ALT, and we think of ALT and alk-phos as being very much part of the liver, they are not necessarily liver specific. ALT you find from the liver, but you can also get it from muscle trauma. The alk-phos, you have a liver and as well as a bone isoform. So we do have some limitations there with those. The other thing is that we may not see these dogs until they're in advanced stage of liver disease because the onset is insidious. That goes back to the wonderful regenerative capacities of the liver, but it also comes down to the fact that, okay, now it's wonderfully regenerative, but what do we mean? Why is this dog so sick? So what are some of the further things that we would look at doing? We look at radiographs. I still like radiographs of the abdomen. I know when I was going through school and also through my residency, some people would poo-poo the idea of abdominal radiographs. They're like, oh, what's it going to tell you? Well, to be completely frank, the best means of assessing the liver and liver size is still the radiograph. Ultrasound can't do that. Ultrasound is much more subjective, whereas when we look at radiographs, we have a much more objective manner of doing it. So you're looking at, is it small? Is it large? Is there a possible mass? Is it lumpy and bumpy in appearance? What about its positioning? What about the position of the gastric axis compared to the liver itself? Also, if you have ascites or loss of serosal detail, that also tells you stuff. If this is non-diagnostic, it may be, but you lose nothing by doing the radiograph. And that's something too that I sometimes feel like people say, well, do I need to do a radiograph? Absolutely. It may give you enough information to say, let's go ahead. Either we need to take the step of going ahead and doing abdominal ultrasound, or maybe we found that there's a mass. Maybe we find that it's also spread to the thorax. So doing thoracic radiographs, looking for a tumor there, is also going to tell you quite a bit. And it changes your discussion with a client. Because at that point, if you say, look, I may not be able to see everything in the abdomen, but I've also got a mass in the chest, now we're starting to talk about a cancerous process. If you say, hey, look, the chest and the abdomen look clear, let's look at getting an abdominal ultrasound. Let's look at going ahead and potentially getting biopsies. Now, abdominal ultrasound, and I love abdominal ultrasounds. I'm internal medicine. We love doing ultrasounds. And honestly, ultrasound is very, very good for getting an idea of the shape of the liver, also its echogenicity. And if you're looking for changes within the parenchyma that you wouldn't necessarily see on plain radiographs, that's going to be very, very good. It will also tell you sometimes if you have abnormal vascular patterns. So if you're looking for extrahepatic portosystemic shunts or intrahepatic shunts, you may find that on your ultrasounds. You also, when you look, just as something to think about, is when you're looking, and these are fairly general and broad thought processes that we have, is with cirrhosis, that's end-stage liver disease, you expect to have a small liver with irregular margins. With copper-associated hepatopathies, you'll often have a hyperechoic liver with regenerative nodules. So it will also look fairly lumpy and bumpy, and some of these nodules will actually be above what we would expect for the normal parenchyma and bulging at the margins. You may visualize portosystemic shunts, but it may also be normal. In one study of 67 dogs with chronic hepatitis, 15 had no ultrasound abnormalities. So once again, is this a perfect test? No, it isn't, but it gives us a lot of information. And once again, if you find something that looks like a mass or a tumor, maybe it gives you some other information to go with. Something else that I like doing is getting abdominal fluid samples. Once again, what we're looking for is, what does this tell us? Well, if you're thinking about fluid, you always think of it as being, do you have a transudate, a modified transudate, but also septic or neoplastic. One of the diseases that we deal with in the abdomen, one of the most common, is lymphoma. Well, while lymphoma is not the most common liver disease and liver cancer, if you have evidence of lymphoma on your transudate or on your fluid, then you know that that's part of what you're dealing with. So it's worthwhile having. And you get abdominal fluid accumulation because of hypoalbuminemia, and increased hydrostatic pressure because of portal hypertension. You can also develop acquired portosystemic shunts. You can also get it because of edema. So there's a lot that the ascites can tell you. Now let's get into the diseases. I know that was long and hopefully didn't put anybody to sleep. So very briefly, I'm going to go through neoplasia, both primary and metastatic. Copper-associated hepatopathy, more because that's becoming something that's more and more common, and you're hearing a lot more about it, particularly in Labradors. Chronic hepatitis is where I'm going to focus a little bit more time. And I'm also going to mention hepatocutaneous syndrome. When we were learning about this in vet school and then also during my residency, all I could think is danger with that. So but it is something to keep in mind. And this is not an exhaustive list. Like I said, I was trying to hit some of the highlights so that we would be able to get an idea of what to expect and what you can see. So starting right off with neoplasia. So you can have primary, and you expect to see hepatocellular carcinomas. It is the most common. And with these dogs, they said in one study, greater than 50% of the dogs that presented for postmortem actually had hepatocellular carcinoma. These dogs may be hypoglycemic. So this is one of those situations where if you have the history of, the dog just, it's 9 or 10 years old, maybe it's not going for long walks, it has to rest, you do your blood work and it's hypoglycemic, hepatocellular carcinoma is on the list as well. Hepatoma, or also known as hepatocellular adenomas, you can have histiocytic sarcoma, hemangiosarcoma, bile duct tumors, both adenomas and carcinomas, fibromas, fibrosarcomas. The liver likes to get cancer, unfortunately. But you also get metastatic tumors. So hemangiosarcoma, histiocytic sarcoma, basically any organ can metastasize to the liver. Like I said, the liver is kind of in the center of the body. It does a lot, and it catches a lot. I put lymphoma as its own, not because lymphoma cannot be primary, but because when I think of lymphoma acts differently. You either get a large, sometimes hyperechoic, rounded margined liver, but sometimes you actually get nodules within the liver as well. Both of those can be lymphoma. Lymphoma in the liver carries a very, very poor prognosis. So when I think about lymphoma, I actually do set it out aside for myself, just as its own category because of the behavior I expect to see from it. So what do you do when you suspect neoplasia or cancer in the liver? The recommendations depend on the tumor or the mass. When you start looking at this, you say, okay, do I take it out? Do I leave it in? If it's solitary, remove it. In hepatocellular carcinoma, if you remove it, in one of the recent studies, they say if you're able to get all of it and get clean margins, you have up to a 3-year survival time. If you're talking about a dog that's 10 or 11 years old to begin with, that's their life expectancy. You've got nothing to lose. If this is something like a hepatoma and you're removing something that's benign, because I know all of us say, oh great, we took them to surgery, we didn't need to. The fact is that dogs with a big liver mass, whether or not it's benign or malignant, that's going to sit there and it's going to cause irritation just from the standpoint that you've got something big that's occupying part of the body. So they're not going to want to eat. They're going to be losing weight. They're going to be losing muscle mass. So at that point, I say, just go ahead and take it out. So you've taken out something that's benign. The dog's going to feel better. it's worthwhile doing. If it's multifocal, then the recommendation is biopsy. The hard part with biopsying is what do you biopsy and how many sites. We know that from current research, they're saying that you need to biopsy multiple sites, because even in you'll see also when I say diffuse biopsy, what they're finding is even if you have diffuse disease, it may not be equally diffuse in all liver lobes. So they're saying get multiple sites if you can. If you suspect lymphoma or a round cell tumor, go ahead and do a fine needle aspirate. And once again, I separated that out because right now what we know from fine needle aspirates in the liver is that it's not as diagnostic as we want it to be. Some of the literature is saying about 25% diagnostic, which in my hands is quite disappointing. And what I tell clients often is, yes, I'll go ahead and aspirate it. If I don't get an answer, it's inconclusive, or it says just normal, I say I don't believe it, I want to get biopsies. If it gives me a diagnosis, then chances are it's accurate. So that's also something that I tend to look into. I've put Scotties in kind of under neoplasia, kind of under in their own separate realm. Basically, Scotties can get a vacuolar hepatopathy. It's a glycogen vacuolar hepatopathy in the United States and France. The median age at presentation is 8 years for the hepatopathy. But what makes this interesting is it progresses in some of these dogs to hepatocellular carcinoma. So it's usually over the course of another couple of years. And so when you think about this, you're going, okay, what's going on? These dogs will look cushingoid, but their adrenal function will basically be inconsistent. They've done low-dose dexamethasone suppression tests on these dogs. They'll do urine cortisol creatinines, and some of them come back as being increased, some of them come back as normal, but these dogs don't respond to treatment for Cushing's disease either. So it becomes a little bit of a conundrum. About 16% of the dogs will end up with a gallbladder mucocele as well. So that's something to keep in mind if you're seeing older Scotties. Now, very briefly, copper-associated hepatopathy. There's currently a lot of research. When this first came out, it was always the Bedlington Terrier is the poster child for copper-associated hepatopathy. However, since 2006, we've known that Labradors have been the more common, partially because we see a lot more Labradors. They're quite a bit more popular than Bedlington Terriers. Sorry, yeah. And what we find is that what I always think of is that they're rather sexy right now. But part of it is that we have better available tests. We know that copper can accumulate either because of a primary copper storage disease, but it can also accumulate because you have damage already to the liver. So those are things that we're now looking at on the veterinary side, is saying, okay, I have copper and I've increased copper. Is it primary or is it secondary? We're still learning that, and we're still elucidating it. Because right now, we knew that Bedlington Terriers, Labrador Retrievers we know, but now they're talking about Dobermans. We see it in Dalmatians, Westies. There's a single case report in a Pembroke Welsh Corgi. And I mention that only because we know that there are other breeds that are now being more affected by it. So it's something that's on the horizon, and so you may start seeing things, you may start hearing things, or you may have clients that come in and say, what about copper-associated hepatopathy? And you're kind of going, wait a minute, let me go and look. It's because there's a lot more information coming out. Generally speaking, we expect these dogs to be middle-aged to older, unless they're Bedlington Terriers. They tend to be younger at that point. Is this more prevalent than previously thought? Well, the current research is now looking into that, and yeah, it looks like it is. And so what we expect to see with a copper-associated hepatopathy is it's characterized by marked accumulation of copper within the hepatocyte. So when you're doing your biopsies, that's what's going to come back. You see inflammation, you see necrosis, cell death, fibrosis, liver failure. And it can be insidious in onset until they are sick. One of the classics for Labradors, and one of the ways that they determined it, was that they would find this most often in postpartum female Labradors that were around 6 or 7 years of age. And they would become acutely sick and go into acute liver failure. So that was something that they were finding too. There was no gender predisposition except in Labradors and Dobermans, which I find very interesting. That's going to play a role in when we're looking also at geographical areas, and also when we're looking at genetics and hereditary things with them. Let me go to this one. Now, chronic hepatitis, multiple breeds are affected. Dobermans for a long time were the classic. There's a female predominance. Typically, we expect to see this With this female predominance, it can also, we know that it can affect up to 12% of dogs on postmortem examination. Bexfield found a predominance of 1.5 to 1 ratio female to male. Median age at presentation is 8 years. But with Dalmatians, Dobermans, English Springer Spaniels, they tend to be younger, so as low as 5.5 to 6 years at presentation. We see it in American and English Cocker Spaniels. American Cocker Spaniels tend to have a male predominance as opposed to a female predominance. But once again, that's based on the population and the geographic location of some of these dogs. Some research out of Japan was saying that it's a lot less male than female. West Highland White Terriers, Skye Terriers, English Springer Spaniels are kind of interesting, just from the standpoint that when we talk about them, they can be, it's in the UK and Norway predominantly in show lines, so it hasn't necessarily come in here, but it's more from those breeds, from those areas. It was a marked female predominance in one study. They tended to have a poor prognosis, and survival time was 189 days, no copper. But it appears to involve the DLA class 2 haplotype, so that either means infectious or autoimmune. Something also about the Westies that I meant to mention is that in West Highland White Terriers, there also appears to be a double population. So one population has more of an autoimmune looking type of disease, whereas the other population tends to have more of a copper-associated hepatopathy. So in all of this, if you've got a dog that you suspect has chronic hepatitis, get your biopsies, always ask for copper staining on them, because you may find that these dogs have something more than just your classic chronic active hepatitis. Our clinical signs, oftentimes it's slowly progressive and insidious. You may see mental dullness and lethargy, PUPD, weight loss, anorexia, hyporexia. If they're icteric, it's already advanced disease. And I think the hard thing here is when I look at this, and even looking at the previous slides when we go through this, these are all non-specific signs. You can see that for so many things. You're basically relying on your physical exam and your suspicion, along with your clinical pathologic findings. Now, with liver biopsies, that's always the gold standard. This is how we diagnose it. They say you need to use the WSAVA guidelines. When I look at this, it always makes me laugh a little bit, because the findings on histopath are going to depend on the severity and the duration of disease. But also, when you look at the WSAVA definition, it's hepatocellular apoptosis or necrosis, variable mononuclear or mixed inflammatory cell infiltrate, regeneration, and fibrosis. This is actually the third definition for the WSAVA that I found. So I'm like, oh, good. And then they say, of course, variations in histologic appearance are between breeds, and the inflammatory cell infiltrate is poorly defined because of a lack of canine-specific reagents. So we sit there and go, okay, well, I'm using the WSAVA guidelines. What do they mean? I still use them because that's the first attempt that we've had to actually make everything uniform. So it's more likely that when we're talking to pathologists or we're talking to other veterinarians, we can all understand we're all on the same page. That being said, I mentioned here the one study. They had, in one study where they were looking at these dogs, they had CD3 positive lymphocytes adjacent to necrotic and apoptotic liver cells. In another study, they found in this similar population, they had an increase of hepatic T lymphocytes. So once again, we're still dealing with some variation. Yes? Oh. No, I thought I had. Okay, where am I? Oh, sorry. Excuse me. I guess I went through the wall. Oh, okay, well, I'll just stand here. Excuse me about that. But what I do expect to see when I'm looking at these histopath reports is I do expect to see increased fibrous connective tissue, bridging fibrosis, and cirrhosis. So those are all things that I feel very confident when they say that that's what we're dealing with. Now, as we said before, these biopsies may contain excess copper because of severe cholestasis and cirrhosis. And as the liver becomes more damaged and loses more cellular function and mass, toxins and heavy metals build up, including copper, manganese, zinc, and cobalt. And one of the other studies that said dogs with chronic hepatic disease and had a copper concentration greater than 100 milligrams per kilogram wet weight also had increase in cobalt, manganese, and zinc. It doesn't mean that these dogs have copper-associated hepatopathy. It's just that you have accumulation of these metals because of liver disease and liver damage. When we look at Dobermans, yes, we tend to think of Dobermans as being the autoimmune poster child for chronic active hepatitis. Once again, there's a second population of Dobermans that have been diagnosed with having a copper-associated hepatopathy. So now we're saying with these dogs, we also need to look at them and say, it's not just autoimmune, it's not just inflammatory, we also know that we have a copper-associated problem. Unfortunately, with these dogs, if we do not find copper, the underlying etiology is rarely determined. This is just a take-home that when I went to a talk by Sharon Center about liver disease, one of her comments was that in veterinary medicine, we use biopsies to diagnose types of liver disease. On the human side, they use it to diagnose the degree of fibrosis. Some of that's because on the human side, they have a lot of viral-associated hepatopathies that we don't see in veterinary medicine. So if you're dealing with someone who's very medically knowledgeable, they'll ask you, well, why can't you run this test or that test and look for viruses? We don't have them. Those haven't been diagnosed in dogs as yet. Okay, yes. Now, very quickly, hepatocutaneous syndrome, also known as superficial necrolytic dermatitis. We see it as an idiopathic hepatocellular collapse. It is usually in small breed dogs, and it's usually middle-aged to older, with an average age of about 10, but it can range from 5 to 15 years. The one exception to that is that there is a hereditary line in the family of Shih Tzus that as young as 2 years of age have been diagnosed with this. You will see cirrhosis. It can be secondary to ingestion of mycotoxins. Generally carries a poor prognosis. I often tend to see them starting out with skin lesions, usually starts on the feet, but it goes to any extremities, so including the nasal planum, periorbital and perianal regions, around the genitals, and also on the pressure points. You will often find you get erythema, crusting, erosions, hyperkeratosis, fissuring of the foot pads. Up to 25 to 40% of affected dogs will also be diabetic. And when I look at them, the classic, the other thing is that there was one study that found that dogs that had been treated with long-term phenobarbital had also developed this. Now that's one study. That doesn't mean that every dog that goes on phenobarbital is going to have this, but if you have a dog that's not feeling well, starts to have these characteristic findings on their feet, go ahead and start thinking about hepatocutaneous syndrome for them too. The pathognomonic finding is something called red, white, and blue on your skin biopsies, and that's parakeratosis, edema, and hyperplasia. Greater than 95% of these dogs will have biochemical abnormalities, so you expect to have an increased ALT and ALK-Phos. The ultrasound characteristic findings have a Swiss cheese liver, and I'm going to see if I can, there it is. And what you're going to see is that you're going to have hypoechoic nodules within a fairly normal-looking liver otherwise, but it has that classic Swiss cheese appearance to it. You diagnose this on skin lesions and ultrasound findings. Originally they said go ahead and get a liver biopsy. These dogs are not the best candidates for liver biopsies. So generally speaking, we base it on skin and ultrasound. Now this is kind of exciting. I'm a nerd and I like stuff like this. So on the horizon, microRNAs. Basically, and I'm going to focus a little bit on microRNA 122, but some of this is general to all of them. Because we're looking for other parameters and other things that will get us into a diagnosis more quickly or tell us that something's going on in the liver, we start to say, what else can we use? So microRNAs are non-protein coding RNAs that regulate post-transcriptional gene expression. They tend to be small proteins. They are highly conserved across the species. They appear to be stable. There is organ specificity for some of them. They are also amplifiable with PCR. Now, the downside with them is that a lot of this research that we're seeing right now is still focused primarily on Labradors because once again, they're the ones that there's a lot more coming out. So there are still some questions about how much this is applicable across the breeds, but it appears to be working well. In humans, they have also, the FDA and the European Medical Association have approved microRNA, specifically microRNA 122, for further study in drug-induced liver injury because they find that this is actually a marker that when it increases, they can follow it, they know that there's liver injury. So it's very exciting from that standpoint, and I expect to see more coming on the horizon. So specifically about microRNA 122, highly expressed in hepatocytes, up to 70% of the total liver microRNA. So if you see this increase, you know that you're dealing with liver disease. It has good sensitivity and specificity for liver damage. Labradors, it's better than ALT. In other breeds, it's also better and earlier than ALT. And we can say that because one of the studies was done by, and I'm going to butcher her name, so it's Osthusen et al. She actually took the research that had been done in Labradors and said, okay, let me see if I can use this in other dogs. So she used multiple breeds of varying sizes, ages, and genders. She found that in this study, it was conserved across the breeds. There did not appear to be a breed, gender, or age or weight difference, which is important. When you're looking at this, you say, okay, can I say that if it's this in a Labrador, is it going to be the same in a Chihuahua? Apparently what she found is it is. It was significantly increased in all dogs with liver disease, including in fibrosis, inflammatory, and neoplastic changes, but it did not differentiate between the types of liver disease. So while it tells us there is liver disease, it doesn't tell us what type. One of the limitations. The other thing is that while there's a positive correlation with ALT, what she found and what she did is she already took dogs that had an increased ALT that had to have liver biopsies to begin with. So from that, we're still saying, okay, can we say that it actually did increase earlier? No, we know that it's higher, but she was saying, I knew that I had to do liver biopsies anyway, so she'd already started out with a biased population. That doesn't mean that we ignore this completely. It just means that there's still some work to be done, but don't be surprised if you start hearing more about it. Even in the last couple of years, there's more that's been coming about microRNAs and different varieties of microRNAs. One of the other studies that I thought was interesting came out with Ragu et al. And they were looking at IL-6, chemokine ligand 2, C-reactive protein, and the AST-ALT ratio. The reason that they were looking at these four different biochemical parameters was that in people, they're using this in people with liver disease that are actually able to run these tests and get an idea about fibrosis, hepatocnecrosis, necroinflammatory disease, and progression of disease. Unfortunately, in dogs, we found that there was substantial variability among the dogs and there was substantial overlap. So looking at this, we can't really say that we can look at IL-6 or chemokine ligand 2 or even C-reactive protein. What we're finding is that they just aren't doing what we want them to do. That doesn't mean that you may not hear more about this. It's just that right now this particular test hasn't told us as much as we want. And so, do you have any questions? I know that was a lot and probably a little dense, and nobody looks like they've fallen asleep yet. So. Oh, yes. I haven't looked at that. I know that what they found is that it's ABCB, well, excuse me, they found that it's the ATP7B mutation that they found is associated with copper-associated hepatopathy in Labrador retrievers. What's interesting about that, going back to when we first talked about copper-associated hepatopathy, originally when they were doing the studies and they found it and they diagnosed it in Labradors, there was a huge controversy about whether or not this was a primary or secondary as copper-associated hepatopathy. The idea was that copper-associated hepatopathies, in order to be primary, you had to find a genetic mutation. So they kept saying, well, in Labradors, is it or isn't it, because they hadn't found the mutation. They found the mutation in COMD1 in Bedlington Terriers, but they didn't find that same mutation in Labradors. When they started looking a little bit further, however, some of the argument was, well, you've got dogs that are presenting with copper levels that are greater than 2,000 parts per million. That's abnormal. Less than 400 is considered normal. This has to be a primary copper-associated hepatopathy. So over the years, they started studying more and more, and they found that there is a mutation in the ATP7B gene. Well, ironically, ATP7B mutation is the same one that affects people with Wilson's disease. So now they've said they can confirm that ATP7B is the causative cause of copper-associated hepatopathy in Labradors. And so when they can find that, they're now able to say, you are a likely carrier, you are one that is going to be at increased risk for it. So that's kind of cool. You're welcome. Any other questions? Yeah. That's a great question, because when I look at those, sometimes I also say, okay, how much is it significant? And right now we don't have a good answer. Would I send these dogs to biopsy immediately? No, I wouldn't. In those cases, I would oftentimes go ahead and do an abdominal x-ray, do an abdominal or thoracic radiograph, and do abdominal ultrasound. Then I would probably follow up in about another month to 2 months. I also tend to start these dogs on Denicil or Denamarin because at that point I've lost nothing. We know that glutathione levels also decrease in these dogs. Maybe all we need to do is add in a little bit of extra glutathione and we start to see some healing and some recovery. If it's a Labrador or a Dalmatian, I'm more likely to say, look, let's go ahead and let's biopsy, let's find out. The other question is, when do you start them on a liver-specific diet? That's another hard one, because I usually save that for dogs when I know they have liver disease, because they're so protein restricted. I'm not likely to do that in an otherwise healthy dog, but that's also in the back of my mind. So, yes? I would say yes in a situation like that, because like you said, if you're going in and it's an older dog or a more mature dog that you're spaying, go ahead and get the biopsy. Is there going to be change over that year? Absolutely, but you've already got it. You're not putting that dog through something that's additional. You've got it saved. I probably would. I do tend to send my biopsies to Cornell University. Nothing against IDEX or Antec, but because of Sharon Center and her presence there, they do their liver biopsies. They're a little bit more expensive, but they do a lot more testing, and so they actually will run copper levels for you. You do have to ask for that, but they'll run some other things. So you've got people who are honed in on, I have to look at liver. That doesn't mean that all the liver biopsies will go straight to the people only doing hepatology, but what it means is that they've got a group of people even working with them that they say, hey, look, if this is a little bit questionable, they're able to go back and say, look, I need your help. I need you to look at this. But absolutely, back to your question, if you're in there, you're getting a liver biopsy and it goes up and it hasn't responded to, let's say, Denamarin or Denicil, even Ursodiol, at that point, talk to them again about submitting it. I don't think you've lost anything at that point. Even if you see fibrosis, what you can assume is, okay, it's because the ALT has gotten worse, chances are the liver disease has gotten a little bit worse too. So yes, good questions. Thank you very much. Thank you.
We appreciate that. Before we go any further, Dr. Barnes with BVSA. Okay. You can do your Raffle.
You stop by. We got a Raffle over here. Just come over and say hi. We've got some prizes over here, Starbucks kind of package, some service cups. So come by and say hi. We're going to raffle at lunch, so swing by as you grab your meal or in between breaks, okay? All right? Enjoy the talks. Thank you.
Okay, next I'd like to introduce Dr. Tracy Lord. She practices integrative holistic veterinary care at Four Paws Veterinary Service, and she sees patients at Four Paws within Dogwood and also within Anderson's Corner Animal Hospital in Williamsburg, and also Dr. Alex Dahlgren, who practices at Cary Street Veterinary Practice and Loving Kindness Veterinary Care. And they will speak on palliative care for the geriatric patients.
Okay, let's see. And while Dr. Parker is not a huge fan of technology, I despise it and it despises me. So we'll see how this all goes. Okay, let me check my time here to start so we can hopefully stay somewhat on track. So I really do appreciate the opportunity to talk to you guys today, and thank you guys for coming out on your otherwise free Sunday. The obvious question is, why are there two of us talking to you for a very short 50-minute lecture? And the answer is that I have used my lifeline and I have phoned a friend. So palliative care is a very broad topic, and Dr. Dahlgren has agreed to do the heavy lifting portion of this lecture and talk to you about medications that you guys would commonly use in palliative care, well outside my wheelhouse. So our goal here is to give you clinically relevant information that you guys can take back and either use in your practice or learn a little bit about some of the other options that you have in the area to help you deal with some of these oftentimes frustrating cases. Okay, so we're going to start by addressing the basics of what is palliative care. This definition that I put up is actually from the World Health Organization from 1990. And the reason I chose this is to highlight the fact that while palliative care is sort of an emerging discipline in veterinary medicine, it's been being looked at in the human field for a really long time. We're probably 50 years or so in their shadow. So a lot of the information that we've got is really coming out of the human side of things. And to some degree, we're still trying to figure out in veterinary medicine what palliative care looks like, and thus it looks different to different people. In general, what we're going to do, in the broadest terms, we're going to talk about palliative care as shifting the focus from providing a strictly medical service or euthanasia service to one where you are providing support for the patient and their family, especially in the face of incurable disease. So in palliative care, the focus is going to shift. We're no longer treating disease, we're palliating symptoms. And it's all about quality of life for both the patient and their owner. The answers here are rarely black and white. And in a way, we're going to take a back seat. Dr. Dahlgren has a slide later that's going to kind of illustrate our diminished role in palliative care. And this is actually often very uncomfortable for us. We are used to, at least within the confines of our exam room, for that very brief period in the day, you are actually in charge of your world. No more. In this case, we are no longer the ones with the answers. We're the ones asking the questions. We're having to take direction from the owner. We're having to take all this into account. And this can be really difficult to do. Leave your egos at the door and figure out how to drive from the back seat without being the obnoxious backseat driver. It's a lot to ask, and it's really taxing when you do it on a regular basis. So what does all this look like? It looks like asking the questions. It looks like using a simple, calm, straightforward manner. When the owners escalate, recognize grief and defensiveness and don't engage. This is not about you. This is about the owner and their process. If you can find empathy, you can speak without judgment and you can listen without judgment. Set the limits as you need, and don't be afraid if this does not work for you. There are other people in the area. Refer to someone else, please. And yes, some of these slides are all in here. I should have mentioned this earlier, I apologize. Slides are all in here. You have some extras. We tried to put as much information in here as we could, even though we can't cover it all. But some of them have shifted in order as we've worked on stuff. All right, so when would you use such a strategy? Well, if you look at the list of diseases that are incurable, you've got cancer, organ failure, arthritis, neurologic conditions. These are your geriatric patients, all of them pretty much. So palliative care is something that we all have sitting in front of us the opportunity to do in our practices. So what we're going to do is look at some of the tools that you guys can use to help make this a little easier. This is the BEEP pain scale for dogs, and it's one of many such scales. On the side that you'll see that I've listed other pain scales that are out there and available. They're all set up a little differently, and I would encourage you to take a look at some of them and see what ones fit you or your practice. I've put enough information in there, I think, to make the Google search a little more streamlined, and so you're not having to search too hard. But these things are worthy to have on hand. The other assessment tool, piece of paper that's worthy to have on hand, is a quality of life assessment tool. And there again are a number of varieties out here. This is the scale. And these can help basically focus the owner's perception of what's going on. University of Tennessee, this one is from University of Tennessee. They also have an end-of-life assessment form, which is terrific. Ohio State has one that says how to know when it's time. Quality of life scale and daily diary by Lap of Love. All set up differently. Take a look. Find one that fits or more and have a copy in your practice. One note on these, a lot of these scales have a grade or a score at the end where greater than 35 passes or greater than 35 fails. This is not that black and white. In some of these we use, let's call it an amended scale, and I'll actually kind of cover up that part as I copy it so the clients don't see it. Because you've got clients who just will focus on that number and you're not going to be able to get them past it. So do I use these in every patient that I have? No, I don't. And maybe I should for my geriatrics and painful patients, but when I try to think about this is when the owner, the patient, and I are not on the same page. And when I'm in a good place, I recognize this quickly in the room, and then there are those other days. And what I recognize is that my frustration level is going through the roof and my head feels like it's going to explode. And I think, this is the time. And I say, let me see if I've got a tool that can help us here. And you can actually grab these. Another one of the great things about having something physical, you can give this to a technician who can help walk the client through them. They can fill all this out while you gather your thoughts if you need, take a sip of coffee, whatever, get yourself together and figure out what's going to be important for your treatment strategy. And then when the technician finishes, you can look at what's important for the owner, have a sense of where you guys are and how far apart you are, and see if you guys can work together. Again, those communication strategies, they're right there again. That's as much for my remembrance as for yours. I think I need to make this a mantra and just say this day in and day out. Always remember that the reason these people are here is because the owner, the patient, or both need your support. They came because they're looking for support. It just may be that what they're looking for is not what you are looking to give, I guess. So assuming you figure out that what you want and what the owners want can mesh, it's time to come up with a plan. And what we want to do is to set up a palliative care plan that everyone can work with and everyone can work within. Again, no one size fits all, so these plans are all going to look a little different. And in some cases, I make them more formal. In some cases, these are very informal. It depends on the client, it depends on the patient, it depends on what we need. Either way, you're going to take into account the patient's needs, the family's needs, and finally what your office can provide. Can you support the family? And you have to make a commitment to support the family through this if you're going to do palliative care. That can be hard, but it doesn't have to all be you. Remember, we're in the back seat now, so someone else can take some of the load and do some of the communication. So the plan is going to consist of 3 components. You're going to have a medical portion of the plan, which thank God we get to be in charge of, something. We're going to have a nursing component, and then we're going to have the component where we're caring for the family. This plan is not made in a vacuum. Your input is going to ensure that the plan is medically appropriate and that your patient's needs are being met. Past that, your client and your patient get to dictate what's happening. In this plan, making this plan, your ability to provide information about a variety of different treatment options, in my opinion, is key. When clients feel unheard, they're going to do one of several things. One, they're going to get angry. Two, they're going to never come back again and find another veterinarian. Or worst case scenario, they're not going to go to anyone. And I see way too many of these guys. And what they generally say is, I used to have a veterinarian, but they didn't listen to me. So I left, I've taken this on my own, and now look, I've brought you this bag of stuff that I've given, and the poor animal is suffering greatly, and this isn't what we want. If you can't meet their needs, if you don't feel their needs are reasonable, there are different options. Maybe someone else can do it. Someone else in your practice, someone outside of your practice. We do have a lot of options in the area, so look for them. One last note about communication, and I'm done harping on it. As veterinarians, I think we tend to use the term suffering more than we might want to. I don't want your pet to suffer, where I think what we more mean is I don't want your pet to be in distress. Suffering is subjective and it's emotional. Distress is more concrete. It's tangible. It's something that we can do something about. It's observable. Distress can actually happen in organ systems. And Dr. Lynn Hendricks has actually put together a list of organ system distress. She's copyrighted it, but she's happy to let anyone use it as long as you give her credit. The following slides here have this broken out by organ system. Some of the organ systems we think of as having distress. When you get down to, let's say, skin distress, we don't necessarily think that way, but that's what it is. And oftentimes, if you put it forth that way, clients can more clearly key in on why this is a big deal. Their animal is in distress. That bed sore is distress. Let me get through these. Okay. These signs of distress are another tool that I encourage you guys to have on hand. Make a copy. Again, you can find it on VIN. We have a copy in full form for clients who need that tangible, what might distress look like. You can hand it to them. You can email it to them. They've got something that they can look at. For some of these guys, we'll also split it out and only give them the portions that seem most applicable to their patient. Again, it's a roadmap. Your technicians can use it. This is what the doctor wanted me to talk to you about, these specific signs of distress. So another thing to consider. All right, I'm now going to turn this over to Dr. Dahlgren and let her talk to you guys a little bit about what you can do about this distress.
The little clicker thing. Hello, I'm so honored and excited to be here, and I feel like thank you, Dr. Lord, for inviting me in the true spirit of palliative care to collaborate with her on this. So I'm going to be talking about the pharmacology and the drugs that we sometimes use with these guys, and I'm going to kind of fly through things. I tried to put more information in your slides, but we just don't have much time, so I'm just going to go over things really briefly. Palliative care, we're managing symptoms, and most of us are pretty good at this anyways. I am only going to be going over the details of pain, nausea, and anxiety today, just because of our short time limit. So when we're treating our geriatric patients, it's just important to remember that they don't absorb or metabolize drugs as well as younger animals, and so they might be more susceptible to side effects. And so some of these age-related changes, you're going to require just mild to moderate dose adjustments. An animal with renal failure is going to require, maybe some major dose adjustments for some of our drugs. Most of our geriatric palliative care patients are going to be on more than one medication, and I use drugs.com to check for medications and interactions. You can type in the list of medications that your patient's on, and it'll provide you with possible interactions, whether they're minor or major. and it'll also give you a list of side effects. Dr. Lord talked about this already quite a bit, but I think it's so important that I just want to mention it again. We really need to make sure that you're asking open-ended questions to your caregivers to really comprehend their capabilities and the patient preferences anytime you're prescribing, whether it's a medication or a treatment, surgery, whatever. If you don't, you're likely to face treatment failure or poor compliance, and those can lead to complicated grief and guilt for the caregiver, and sometimes even premature euthanasia. In palliative and hospice care, our expert opinions get dialed back quite a bit, and the caregiver's preferences and capabilities get turned up. So we have to do a lot more listening and less talking when we're dealing with end-of-life and chronic and palliative care situations. I'm going to talk about pain first. I think it's the most important one and probably the one we see most commonly in our palliative care patients. There's lots of different types of pain, and there's lots of different modalities and drugs, and some of them are going to work better for certain types than others. Most of our palliative care patients have chronic or maladaptive pain, and they're going to require more than one drug to treat. I typically start, when I think about pain, I kind of think about layering on pain medications from mild to moderate to severe pain. And I usually always start with an NSAID for mild to moderate pain. Sometimes nutraceuticals, sometimes Adequan, omega-3 fatty acids, acupuncture, rehab, all of those things you can start with mild to moderate pain. However, if all you use is an NSAID in your osteoarthritis patients, about 40% of them are going to fail without the addition of another drug. And I usually add in gabapentin. I usually start at 5 to 10 mg per kg, and then I increase it to effect, kind of titrating it up every 3 to 5 days. I usually increase the evening dose first, and then a couple days later the morning dose. And by doing that, I'm trying to avoid the sedation that will make owners stop giving it. Most of the geriatric guys are going to land in the 5 to 10 mg per kg range, but not always, and you can safely increase this drug to 50 to 60 mg per kg or higher. For moderate pain, I'm usually going to add on amantadine if the owners can afford it, and/or tricyclic antidepressant, and/or acetaminophen. And just a note, Tylenol, you can use Tylenol with NSAIDs. It has a long safety record. I know it makes us nervous, but I've found it to be pretty well tolerated long-term in geriatric patients. Of course, you would not use it in hepatic disease and never in cats. So here you may be tempted to add in tramadol. I know I used to use a lot of it, and we still wish that it worked really well, but it doesn't. There have been lots of studies that show that it really isn't a great pain medication in dogs. And I think sometimes if you're seeing some improvement, what you're probably seeing is it is a tricyclic antidepressant. It's not a great tricyclic antidepressant, so if that's what you want, I would use a tricyclic antidepressant like amitriptyline. It's controlled and has an extremely short half-life in dogs. It is a good pain medication for cats, and I actually have found it to be effective transdermally. For moderate to severe pain, I am usually going to be adding in an opioid. I typically start with buprenorphine, and there's lots of doses and stuff about buprenorphine there you can take a look at. But for severe pain, I'm going to be adding in a full mu agonist. And I do use oral opioids sometimes. Codeine has about a 4% absorption rate in dogs, so I think if you're using Tylenol for whatever, you're probably seeing improvement from the Tylenol. Hydrocodone has about 80% absorption, so if I'm going to use one, I'll usually use that one. And I do teach owners to give sub-Q injections of full mu agonist at home. If they have a pain crisis, until they can get a hold of me, they can use that drug. or if they're just trying to get on wind up, I try to limit that to less than a day or two. These drugs have lots of side effects, so try to get on top of the pain as soon as we can. With severe pain, I'll also sometimes we can do a pain vacation. And so this is where you hospitalize the patient and you put them on a sub-anesthetic dose of a CRI of ketamine, plus or minus lidocaine, plus or minus a mu agonist. And that just helps you get on top of the wind-up. If you have like a chronic neuropathy just hasn't been responsive to your oral meds, this can sometimes be helpful. And you can repeat it periodically. So nausea, also common in our palliative care patients. And like pain, there's lots of different reasons they can have nausea. I use a lot of Cerenia. I'm sure you guys do too. It's an amazing drug for vomiting. I do teach people to give this sub-Q. Again, if they have an acute crisis where the animal's vomiting, I teach them to give it sub-Q. It isn't a great drug for nausea, so if I feel like they're really nauseous, I usually will reach for ondansetron. There are so many different antiemetics. I just have a pretty good comfort level with ondansetron. If they're not eating, I'll use the orally disintegrating tablets. I do sometimes add in mirtazapine, especially if I feel like their nausea is milder and maybe doesn't need as strong of a drug as ondansetron and they're just not eating that great. Ondansetron and mirtazapine have similar modes of action, and if you're using them together, which you can, you just have to be careful about the serotonin syndrome. I haven't really seen that much, but just be aware of it. And mirtazapine does decrease the effectiveness of ondansetron. So depending on what you need, you might want to back off on one or the other. And these other antiemetics, I think you are useful in certain situations like vestibular disease or LARPAR or whatever. So what else? So antacids. The ACVIM just released a consensus statement this week on antacid use. And I used to use a lot of famotidine. It doesn't seem to so for chronic use, famotidines, they seem to develop resistance after 2 or 3 days, so they recommend using basically a proton pump inhibitor like omeprazole if you're going to be using a chronic antacid. And basically the consensus statement was saying not to use these drugs unless you have a specific, unless you really suspect they have gastroesophageal reflux disease or ulcers, so not to use them routinely in chronic renal failure or chronic hepatic disease. They just really aren't worth it. And appetite stimulants, I talked about mirtazapine a little. And I didn't mention this, but it is available as an FDA-approved transdermal medication for cats. It's pretty affordable, and I use it, and it's effective. I like it. I do use this drug probably more often because I feel like it does help with nausea. So if I have like a chronic renal failure patient who's not eating, I think it's a good choice. I've used Entice a few times. I haven't had good luck with it, but the studies show that it's helpful. I probably just haven't had the right patients to use it on. I do think with any time of appetite stimulant, there's some ethical concerns. It can be really controversial. You want to make sure you've ruled out pain, anxiety, and nausea before you make the dog hungry. And just to remember that if a dog or an animal isn't eating because they're not hungry, while we do want to support them nutritionally as they approach the end of life in their last months to weeks, not being hungry is not necessarily an indicator of poor quality of life or distress. And so sometimes that's just a conversation we have with the owner where we say, you know, it's okay. It's okay that he's not eating. It doesn't mean he's in distress. This is normal. This is a normal part of approaching the end of life. And then for anxiety and sedation, we need to make sure, again, that we've ruled out pain and we've addressed any environmental changes that we can. And that said, I don't hesitate to give these animals drugs to make them go to sleep, stop pacing at night, because if you don't address this, this can lead to euthanasia pretty quickly. I have listed a lot of anxiolytics again. I use a lot of trazodone. I feel like, especially in the older guys, it's pretty well tolerated. It's a pretty safe drug. It is a serotonergic drug, so just be careful if they're on other serotonergic medications. I haven't had problems with it in that respect. And I also use high doses of gabapentin for anxiety in my older guys. I listed some other here that have more side effects, like the benzodiazepines I don't use as much, but I do use them sometimes, and clonidine. And then, of course, the tricyclic antidepressants, the SNRIs, the SSRIs, those take a little bit longer to start working, but I do use them sometimes. Lots of things we didn't have time to talk about, and so I included at the end of the notes a list of resources that I think are really helpful if you're looking for more information on palliating your patients. These are some great places to look. I'm always happy to talk. I love talking about this stuff, so I'm always happy to talk to you guys about it. I think every patient's different. There's no right answer for everybody. And the resources that I included at the end are really helpful if you're interested in learning, more about specific drugs, more about specific approaches to palliative care. I think that the hardest thing to do is to change the way you think about how you approach end-of-life care. And if you haven't read this book, Being Mortal by Atul Gawande, it's a fantastic read. It's really good. He's a surgeon who wrote about end-of-life care in the human medicine, and it really changed the way that I think about it. So I highly recommend it. And now I'm going to pass things back to Dr. Lord.
Good? Okay, fantastic. All right. All right. Continuing on with the audacity portion of the lecture. Okay, so integrative therapies can play a very important role in our palliative care situations. And there are many different treatment modalities to choose from. Don't be afraid of them. They're not that scary, and they're not that crazy. Now, some of them are a little outside the box, but it's okay. I do expect significant improvements in quality of life when I'm adding in alternative therapies. This isn't for fun. It's really making a difference. But I'm not taking away drugs either. So if you send your patient and they're on a moderate to severe pain control regimen of medications, that's what they're staying on. They're generally coming to me because it's not enough, or because we've got some side effects that are a problem, and the animals can't maintain this longer term. So the goal is to improve quality of life and then look at starting to minimize, starting to take away as we're able to maximize their actual quality of life. The layering of therapies, just like layering the drugs, layering of therapies is important, and this is where I feel like we're most effective. But when we do it well, the results can be better than we ever dared expect or hope for. This is Jolene. I love Jolene. So Jolene came to see me on emergency in August, and everyone laughs. A holistic emergency. Holistic emergencies are just like everyone else's emergencies. The dog was painful. The dog couldn't get up. The owners were considering euthanasia. They carried her in. Her vet did just what he was supposed to do. He had assessed her earlier in the week, did some x-rays, found collapsed disc spaces, severe TL junction, put her on some pain medications appropriate for moderate pain, had her go home, rest, and see how she did. Surgery wasn't an option for the dog. He called us on Friday and said, oh my God, she's bad. The owners are considering putting her down. Is there anything you can do? We worked her in on Saturday. I was in my secondary location, so we just did acupuncture on her because that's what I had. She came in and she couldn't get up. When you helped her rise, she used her nose as her fourth leg. And when I assessed her, this left elbow here is terribly arthritic. And we did x-rays, severe arthritis in that. And I felt like at this point, the elbow was causing us even more trouble than the back. So we started with acupuncture, and I sent her home to rest, back in 3 days to repeat. She actually saw Dr. Dahlgren over the weekend to reassess to see if they needed to put the dog down. The owners were very dedicated, and they were very concerned. She determined that the dog was fine, okay, not fine, but okay, good enough to manage, assuming we were going to see improvement. Gave him some pain medications to have and give in case they felt they needed. Increased some gabapentin. The dog did sleep, given the increased dose of gabapentin, which worked. It got him through the weekend. I saw her again on Monday. When she came in on Monday, we repeated our acupuncture. We added in ozone injectably around the joints. And after that second treatment, she started to see results. We built from there. Right now, Jolene is on very minimal pain control so far as conventional medications goes, as needed. She's on one nutraceutical supplement for pain and inflammation, and she's coming in once a month, and we're still expanding our treatment plan. So right now, she's out to every 4 weeks where she comes in. But Jolene is back. She is being herself. This is what palliative care can and should look like. This is what it can look like when we all work together. And this is her and her mom. They love one another. All right, so let's look at how we can do this. So first I'm going to talk about herbs and supplements a little bit. Please ask your clients specifically about what herbs and supplements they are taking. Ask 3 ways if you have to. Yes, herb-drug interactions are a real thing, and that's because herbs and supplements actually do something. Amazingly, that's why we put them on it, and that's why we can cause problems. So we have to be careful, just like we have to be careful with our medications. So they're not to be avoided, in my opinion, but they're to be used with caution and respect. Interactions can be synergistic. So we can use these things with drugs to help lower the drugs that we need to give, decreasing side effects, helping everybody out. The effects are real, they're not random. But when we're using them, we do have to be careful that we're not going to get interactions that we don't know about or don't expect. WebMD drug interaction checker, sorry we can't see our slides here that well, and also Sloan Kettering Cancer Herbs Database are 2 really good resources. And you can put in both drugs and herbs into these, and they'll let you know interactions. The Sloan Kettering actually has an app that you can get on your phone, which makes it nice and convenient. One note, I feel like when owners are using the kitchen sink approach to herbal medicine, the basket, I think all bets are off. So just like when we've got an animal on 6-8 drugs, yeah, maybe we know what they all do individually, but when we layer those all together, you start seeing things that you don't expect. That's what happens, and the same thing happens with this. So I encourage people to get off their multiples. I try to use a lot of formulas where I know what the formula is going to do together, and I can accomplish a lot more than I can accomplish by giving all these different things. Just also quality of life. You know, you don't want to be stuffing pills down a patient all day long, and I spend a lot of time talking to people about that's not quality of life. Okay, so we know herbs can have effect. They can affect blood glucose. They can have hypoglycemic effects. This can be great when you've got like a borderline diabetic or a diabetic who's not being well controlled with their insulin or food or whatever it is. And sometimes these things can help kind of smooth out the edges. Know if you've got a fulminant diabetic who's in crisis, you can't give them bilberry and make it all better. It's not going to work. Well, let's be logical. But when you've got clients who want to use these, I'm not afraid of them. I don't mind adding them in if you've got a diabetic, who you're working with. Now, if you've got them well regulated, warn the owner they can upset the apple cart. I mean, you've got to make modifications as they're adding stuff in. And if they're going to change your treatment plan, they have to be willing to do the testing that's appropriate. Just because you're using herbs, just because you're using alternative medicine does not mean that good medicine goes out the window. Things that can potentiate bleeding. I just want to highlight fish oil here for a minute. Fish oil is fantastic. We know it can be very useful as an anti-inflammatory for skin, for GI, for musculoskeletal, for all sorts of things. There's question as to whether fish oil is really going to potentiate bleeding, and I think most studies say that in a healthy animal it is not, even at high doses. But most of these geriatrics are not healthy animals. And again, when we have comorbidities going on, when we have other things happening, when our liver or kidney or whatever is not working as well as it could, should, or would, I think we have to be careful. So when you've got a patient who you're concerned about a bleed, I encourage you to ask specifically about fish oil. It's so ubiquitous that people don't even consider it. It's not a supplement, it's just part of their diet. So ask specifically about it. There are other things that you can use as anti-inflammatories. They don't have to be on it. Getting them off, recommend at least 3 days, 2 days before surgery. Great. Just give yourself a little extra safety. We don't want to cause any problems. There's no need. So I'm most cautious about adding in herbs to medications with my cardiovascular patients. I don't want to mess those up. And generally speaking, I'm not going to be adding in any of these things listed below if I've got a patient on actual cardiac meds. I will use Chinese herbal formulas in these guys that are known to be safe and can work well with the medications that they're on. And just a note about Chinese herbal formulas and kind of how they differ, since we're here. Chinese herbal formulas are formulas. So the way that they're set up is that you've got a major herb, a major player in there, and then you've got other herbs in supporting roles. And one of the things that they've done over the years, and some of these formulas are thousands of years old, is that when we've got major player herbs in there that are known to have side effects, let's say GI distress, it's known to cause diarrhea, vomiting, whatever it is, within that formula already are contained other herbs to help deal with that before it even starts. So you're going to see, let's say, ginger or peppermint or something like that in the formula. So herbal formulas are a really nice way that you can get in multiple herbs that you might want. One with safety because they are done in a set manner. And they've been looked at and used extensively in this particular formula. And I tend to use, most of my Chinese herbals are designed for pets. They're not actually designed for humans because our pet formulas are shifted a little bit as they've been shown to work better. But they tend to be pretty safe, and they can have things like cardiovascular significant effects without affecting or whether that is potentiating too much or working against the medications that are already on board. As we're talking about Chinese herbals, let's talk about Yunnan Biao. Okay, how many of you have prescribed Yunnan Biao to a patient? Many of you, yeah. It is one of the most popular ones out there that everyone loves to use and send home because it is great for bleeding. And I love Yunnan Biao. I think it can work fantastically. That said, it is super sketchy. So this is going to be one of the only herbal formulas that I use that actually comes out of China. Most of mine are coming out of Canada or the US. The herbs are sourced there. It's all processed there. This is coming out of the Yunnan province in China. Just recently, we actually learned, thanks so much for telling us, that Nodopanic pseudoginseng is the major herb sanqi that's in there. We didn't even know that before. There are supporting herbs in there as well, and those can vary. And we're not convinced that we actually know all of what's in there because this is proprietary. So use this with respect. note with your clients what you're using. Now you're doing it because you've got a severe condition and you've really got nothing else to do, right? So what do you have to lose? I'm all about it. Give it, recommend it. How many of you know who use it that there's a hit pill in the middle of that package? Good job. About, an eighth of the people who use it. So within that little sleeve that you have all those capsules in, right in the very center is this teeny tiny little pouch. And in that is a little red pill. It's called a hip pill. And we have no idea what is in that. It is, yay, just what we're looking for. It is used for emergencies. So this is the emergency bleed pill that you give. I have clients save them. You got them, don't throw them out with your sleeve. You can save the sleeves or pop them out and really put them in like a plastic bag and save them. Generally speaking, if I have a client who feels like they have an acute bleed, I tell them to give one. Repeat within 10 minutes if it's not helping and the animal's not improving. If I have a good owner, big dog, I may tell them to just, if you know you have a problem, I'm pretty confident you know what this looks like, give multiples. Your dog is actively bleeding out, and I will give multiples when I have a dog bleeding out in front of me, because really, what do we have to lose? But reality is, this can work very nicely for bleeding. Hemangiosarcoma patients, terrific. Epistaxis used topically. If you get it up the nose, we've done that. And darned if it doesn't stop bleeding. Fantastic. Wounds that you can't get to stop bleeding, you can use topically. And in human medicine, I don't think I've seen it in veterinary medicine, but in human medicine, they've actually got some people who've looked at giving UNAM/BIAO days before surgery when they're doing whatever particular surgery it is, and they've collected, because it's human medicine, the amount of blood that they're getting from the patient, and they've found significant decreases in bleeding during surgery. So just something to throw out there if anyone's brave enough to do that. I'm not doing surgery anymore, so I don't have to consider it. But it really is a fantastic drug as long as you're careful with it and recognize what you're getting and what you're using. On that note, please don't send your clients to Amazon to get it. I beg of you. Yes? If I have a hemangiosarcoma dog who still has their spleen, without their spleen, if I have no evidence of a bleed, I generally have them on a Chinese herbal formula, which is going to have some of that san qi in there. And I am generally not using UNAM/BIAO as a singlet, as a single formula, because it is only doing bleeding. So I tend to use another formula that can help with bleeding, but is also more anti-cancer than this particular formula. But I'm not opposed to using it. But in my opinion, if you don't have an active tumor, now another one can show up, right? And if I've got a secondary one in the liver or whatever, it's another story. But if I'm pretty comfortable that I've got a period of time where I shouldn't have a tumor that is going to actively bleed, I tend not to put them on it because I've got other things that I would rather have them on. But I don't think it's wrong to do it. Especially at a lower dose, just use a little bit just to have it in there on board. And then if you're starting to see signs of kind of the slow bleed, go ahead and increase it then. Okay. Yeah. Okay, sourcing. So on here you've got several reputable sources for UNAM/BIAO. A Time to Heal and Jintong are veterinary distributors. Mayway is a human herbal company. All of them are legitimate. You set up an account just like you would for any medication. Order it from there, please. It's hugely counterfeited. Lord only knows what you get when you go off of Amazon. All right. So let's talk a couple minutes about essential oils. We actually have some information up on our website. It's under services, which is probably not the ideal place to have it, although I do use essential oils, but not a lot. But we put a post up on Facebook and then put it on our website in January, I think, when all the scuttlebutt was going on about safety in cats, and we were getting literally 10, 15 calls a day about essential oils in cats. The long and short of it is, when someone calls and says, can I use this oil with a cat? I don't know, because I don't really know what it is. Oils come in many different qualities. Some of them are no more than air fresheners. They're chemical products. A true therapeutic grade essential oil might be safe, but your chemically created essential oil, which is the same scent, is not. We use animal EO essential oils. These are created by Melissa Shelton. She's a veterinarian. And those are the ones that we carry, and I feel pretty darn safe with them. I've never had a problem. She tests them extensively. She says they're tested on humans. And she does. She tests her new formulas on herself, her husband, and then her children before she starts applying it to the pets. She's got an extensive website. It's really client-based, and I think it's way overstated, so I'm not really a huge fan of her website. And it probably does a disservice to essential oils, in my opinion, ultimately by saying that it does things that really it doesn't. It's not. But anyway, but the oils I think are safe. And that's what's important. So I feel pretty good about using them. Clients can get them if they want. So if they're asking you about essential oils, it's a pretty darn safe place to send them. And she's got extensive information about all of her formulas, how they're to be used, how they're to be diluted, that sort of a thing. doTERRA and Young Living are also very reputable companies that do essential oils. They both have animal lines. I don't know their products that well, so I can't guarantee, but I've never seen a problem with it, and I know the oils are good. And really, essential oils, you can use some. We use this as a layering therapy, and for some of these guys, it really does seem to make a difference. Helping to take the edge off. It can help to take the edge off of the client if they're petting it on. Very nice. So they are very useful, and if you need, you can send people to our website, and they can find that information. All right, a couple notes about acupuncture, and I'm actually not going to talk much about acupuncture. Except to say that I think it's fantastic and I use it all day long. Acupuncture and palliative care go so well together, and I was super impressed to see that they actually do have it listed in Veterinary Clinics of North America's book on palliative care. It can serve as an important addition to a comprehensive care plan, particularly for those patients facing pain issues. It is not a panacea. It may be used alone in the face of musculoskeletal pain, but if applied in conjunction with more conventional pain management modalities, it provides a synergistic effect. I cannot agree more. It's very useful. I use it even in cancer patients. You do have to be a little careful in cancer patients that we're not potentiating tumor growth, but you can use it. You can use it safely in cancer patients, and it can really help make them feel better and help them do better. This is just a study that was published in the American Journal of Hospice and Palliative Care in 2008. This is a human study, and what they did is they looked at 27 randomized controlled clinical trials that they felt met their standards. And they reviewed them. Of those, 23 recorded statistically significant results favoring acupuncture's use for conditions appropriate to treat in palliative care. Again, human medicine is a little past where we are in our recognition of what happens in palliative care. But don't be afraid of it. Spinal manipulation, another very useful tool, one that I use a lot of. Again, a note from Veterinary Clinics in North America, recognizing that yes, it can be helpful. One, you do have to be careful with conditions of acute back pain, but in chronic conditions, chronic disc issues, it's pretty darn safe and can be used very effectively. One place that I find that it works really nicely in many cases is with urinary incontinence. Oftentimes those that have not responded to Proin, or when you've got the males and you've got nothing to offer them. The lucky ones, and I love these because they make me look really good, and that's great. The lucky ones, you can adjust, and what you're doing is restoring normal movement to a spinal segment. That movement, what happens when something needs an adjustment is that the spinal segments are stuck. They're not moving at all. It's like your elbow and it doesn't go any further. What should happen with a spinal segment is more like your finger. When you push it out, there's a little play at the end, and that's what you should feel between vertebrae. When you're not feeling that, you're not getting this movement, which is going to actually be nourishing those afferent and efferent nerves, letting them work well. And when you adjust them, the nerves work better. Some nerves affect the bladder. So when we're lucky, these incontinence dogs can, boom, clear up. They're my favorites. They're fantastic. In probably at least half, it's greatly improved. So it can be a huge help, and it's pretty quick to figure out if it's going to help or not. If it doesn't within 2 treatments, I move on to something else. But it's a nice one to try. You oftentimes do have to continue with it at some interval, depending on the patient, to maintain response, but it's terrific. Physical therapy. One, you don't need an underwater treadmill to do physical therapy. We do have some fantastic physical therapists around, however, who have underwater treadmills and other things, and they are great. Use them, refer to them, please. If nothing else, if you're not comfortable talking to clients about basic exercises they can do to help quality of life in their patients, physical therapists can. If nothing else, to get them in and talk to clients about what they can do with their dogs at home and how to do it. If you're directing your clients, the biggest thing that I see, you've got to remind them, especially in these seniors, is to start slow. 2 minutes, 3 minutes can be a really long time to work for some of these seniors. Also start low. Anything you're doing has to be very safe. For having, working with, let's say, the animal being able to recognize where their feet are, walking over, whether you want to get fancy or not, I generally have them put like pool noodles down. A lot of people want to use a ladder. Well, if you stub your toe on a ladder, it's going to hurt. So until they get good at it, use something soft, use something movable, be creative, but be sensible. And if you're not comfortable, like I said, refer to a physical therapist. My ideal for patients for these seniors is I want them moving for 20 minutes, once to twice a day, preferably twice a day. That may be to the mailbox and back, but I want to get them up and moving for 20 minutes twice a day. They need to move. Ozone. You can see by my very busy slide that I love ozone. I don't have much time, and I tried to stuff as much in there as I could. So ozone, or O3, is an unstable oxygen metabolite. It is not recognized by the United States as having any medical effect. However, in Europe, Germany, Italy in particular, and a number of other European countries, they use it extensively, and I find it very effective. What it does. So ozone is known to be anti-inflammatory, antibacterial, antifungal, anti-all sorts of things, and it can be given in many different ways. We inject it around joints. We'll infuse it in fluids and give it as part of our sub-Q fluids. We'll even give it IV, and to do that, we take some of the patient's blood, infuse that with the gas, add some vitamins and minerals, and then give that blood back to the patient. So I'm not injecting a gas IV. Again, basic medical principles always apply, please. But it can work really nicely, and it has a good bit of actual scientific basis behind how it works. What it's going to do is it's going to stimulate cellular mitochondria. And when you look at the difference in cells between your children and yourselves, or someone else's children and yourselves, the biggest difference is the cellular mitochondria and how well they work. The theory behind ozone is that the diseases of aging are potentiated because of decreased oxygen utilization, and this is going to cause increased free radical production, and much of this is going to be because of our mitochondria. So the ozone is going to go in and it's going to shift the NAD-NADH ratio in order to help cells help the mitochondria work better. And there are all the nice pictures of how it works and where it works in the cycle and whatnot. But basically, it helps make them feel better. Ozone can, we say it goes where it needs to go, and everyone starts rolling their eyes, but it really does. So we know, we measure the ozone level, and we say the air is polluted because the ozone levels are high. The ozone isn't the pollution. The ozone needed to be there to clean it up. That's what the ozone is there for. And it came in because the pollution was there. So it comes in secondary to the pollution. It's just the easy thing to measure. So that's how we measure it and determine how much pollution's in the air at the time. It is a respiratory irritant. You can't breathe it in directly. So we scavenge it and do all that other stuff in order to be able to use it safely. But I use a lot of it. I love it. Added it into Jolene because elbows are particularly difficult to deal with when you've got these really arthritic elbows, and I think it made a big difference. IV vitamin C, another of my favorite things. So at high doses, vitamin C goes from being an antioxidant to an oxidant. It's actually a selective oxidant. So it goes in, and healthy cells have a catalase to break it down. Unhealthy cells and cancer cells do not. So it can be very effective to be used in cases of cancer. Erin Bannock is a veterinary oncologist who's also an herbalist. She recommends IV vitamin C definitely in all of her osteosarcoma patients. She finds it particularly helpful in those. I use it in a lot of cancer patients, and really a lot of patients, anybody who has inflammatory disease, it can be very helpful for if clients are up for it. All right, that was the hard part. For the final little bit, these are a few of our favorite things. These are just some things that we wanted to share with you guys that both Dr. Dahlgren and I love. So carts can be great for dogs. I always talk to owners, especially when they've got bigger dogs, about the fact that they're having to put a movable dog into a movable cart. Some clients are not able to do that. It is not worth their health to get their dog into a cart. Ginger leads are terrific. They provide a moderate amount of help for the back end of the body. Walkabout harnesses down on the bottom have more support for the hind end and can work really nicely. Beco braces, oh look, I've got a pointer, I forgot about that. Beco braces, great for the neurological dogs who can't get those feet moving forward. It just helps them kind of pull those back feet forward and helps them place. Note on that, most of those dogs that you have are really weak. And the biggest problem that I see with these is that people send them home with owners who put the Beco brace on their dog in the morning, and by noon the dog can't get up. That's because this is pulling their leg forward, and they're having to work really hard to pull that leg back. And it's too much. You've got to start slow. You might have them put it on for 3-5 minutes at a time to start and work up gradually. Just be careful with these. We're looking at, we've got fragile patients that we're dealing with here. Help them up harnesses, one of my favorites. It's got a handle right in the middle of the dog here, and it's got another handle at the butt. They fit really well, they stay on really well, and that's a harness that can stay on for the day. People do have to take them off at night. If they get wet, you can get really nasty bed sores underneath there, so make sure your clients aren't getting lazy with that because they can cause themselves major problems. Finally, over in the corner here, a rough wear harness, another of my favorite harnesses. These used to be built a little better than they're built now, but they're still terrific. They've got a single handle in the middle of the dog. So for those dogs who have issues in both the front end and the hind end, you don't want to use something like a walkabout harness, which, yes, is taking pressure off that back end, but the poor front end is just suffering, and the dogs aren't doing well with it. And it's just that you have the wrong harness. Helping with traction, Dr. Dahlgren and I both love Dr. Busby's toe grips. These can work really nicely, but you have to be sure you've got the right nails. There are some dogs where when you put the toe grip on, it's not going to touch. It's got to be able, and I can't even get my pointer there, it's got to be able, the toe grip has to be able to touch the ground. And you can see when you look at how these dogs' feet are built, whether that's potentially going to happen or not. They tend to stay on pretty well just by force of friction when the dogs are walking. If they don't, we tell people they can put a little dab of super glue right on the top of them. I never super glue them on the first time. If the dog hates them, which they usually don't, I want to be able to take them off. Paw friction, it's sand that you glue on the bottom of their feet. You can end up with more sand and glue on your fingers than you end up on the patient's paws, but some clients get really adept at using this, and it can be very helpful. It does wash off easily and wear off quickly. So let owners know that that is something they're going to have to deal with and reapply frequently. More for slipping and sliding flooring options. I recommend a lot of yoga mats. They're cheap and easy to get. You can buy them in rolls on Amazon. You can throw them in the washing machine. Yes, they will break down over time, but that's okay. Non-slip runners for stairs, or these treads. These are, oops, sorry, wrong button. These are little clear treads that you can stick on the steps to make them a little less sticky. And finally, these interlocking foam tiles. You can find them in Lowe's and Home Depot. They have them for kids. They have them for in-home gyms and whatnot, and they work really nicely. One note about those, if you get water underneath them, they slide out from under you like an ice skating rink. So be careful that owners know if they wash them, you've got to dry them thoroughly or you're gonna hurt yourself or someone else. Finally, be kind to yourself. If you're dealing with palliative care patients, it's a lot. It can be very wearing. We know the issues that are facing veterinary medicine at this point, so just watch out for it. May you be kind, may you be well, may you be joyful, may you be at peace, and may you enjoy the rest of your day. Thank you, guys. Questions? Yeah.
Earlier you were talking about the quality of life worksheets. There is one that I've used extensively by Gentle Goodbyes.
Okay.
6-page quality of life assessment.
Okay.
For the owners. I'm trying to be, the owners would come back to me later on and say, how can we make the cases? So these are questions like, would you want to do this way?
Right.
To adjust every ounce of eating to the dog's activity. Such as one of the other ones that really been helpful.
Fantastic.
By Gentle Goodbyes.
By Gentle Goodbyes. Gentle Goodbyes. Okay, great. Great, thank you. Yeah, there are a bunch of really good ones out there. That's fantastic. Yeah. I avoided CBD oil like the plague. Okay, so in short, I just sent my CBD oil back. I love CBD oil. It works on the cannabinoid receptors in the body. Cannabinoid receptors are everywhere in the body. We know this, so that's why CBD oils can have such a great range of effects because they can attach anywhere through the neurosystem, musculoskeletal, et cetera, et cetera. The problem with CBD oils is that in Virginia right now, the law is written so that a CBD product with no THC in it is classified just like pot, just like marijuana. So to use it legally in Virginia at this point, as far as I can tell, and I sent this off to my company who said, of course you can use it, that's stupid, da-da-da. I'm like, well, look at this law and you tell me how I can manage that. And they said, yeah, we'll take your stuff back if you want. It is, you've got to use it legally, you are restricted in the number of days. You have to actually send in client information so they can be registered medical marijuana users. That's got to be upped once a year. It's just not manageable in my opinion. The law does say that they are welcome to get it online, so I just find that fantastic. So they can get a lesser product somewhere and buyer beware, and that's the way we're dealing with it right now in Virginia. I'm really hoping that law changes. But that came about with our legalization of marijuana. Anyone else? Fantastic. Thank you, guys. I really appreciate it.